All right. I'm Lou Hawthorne. Thank you. Hello. And I'm the founder of NaNotics and the inventor of the technology that I'm going to talk about today, which is called nanots. This is a new class of medicine for adsorbing soluble drivers of diseases and aging. Soluble meaning dissolved in blood or the water of tissue. So I presented in 2022, and thank you, Morton and Alex, for inviting me back. I have new efficacy data in cancer in humanized mice. We also have a new preclinical study in process in MS. We have new white papers, and we've declassified several of our internal white papers, and we're going to be putting up QR codes if you'd like to download them and read them. They're very detailed. We also have new aging-specific nanot targets and new patents. We now have 38 granted patents, up from 15 in 2022. Okay, so historically, disease research and drug development has been very cell-centric since the invention of the microscope over 300 years ago. Existing drugs are mainly antibodies targeting cell surface receptors, or they're small molecules that likewise target cells. However, soluble factors are often direct mediators of disease and arguably more relevant targets than cells. Soluble factors in conjunction with cells form a dynamic system which is dysregulated in disease and aging. And depleting these soluble factors can actually reset the entire dysregulated system, including dysregulated cells, without targeting the cells. And we have proof of that coming up. The problem is that the existing drug class, particularly antibody drugs, are poorly suited for soluble targets. Nanots are purpose-built from the ground up for soluble targets. So, nanots are fabricated using biodegradable materials and modular chemistry, which is repeatable, scalable, and safe. There's a core, which is the structure upon which we build. Onto that, we attach capture agents with specific soluble target affinity. Onto that, we attach a porous shield that makes the nanot specific for soluble targets, which diffuse through the shield, but it prevents any engagement at all with cell surface receptors. And finally, we attach a stealth coating just to delay immune recognition and clearance until the capture process is complete. It ends up being 150 nanometers across. That's the size of a typical virus. You inject it like a drug, but it's cleared naturally by macrophage phagocytosis. It's basically a molecular sponge or molecular apheresis. And we build it using click chemistry, which is modular. It won the Nobel Prize in 2022 in chemistry. Okay, so this platform is fully validated and extensible. We can develop nanots very rapidly against virtually any pathogenic soluble target. We've made dozens of these so far. We've demonstrated that nanots against soluble TNF, the master inflammatory cytokine, shifted mortality in a mouse model of cytokine storm. We've demonstrated profound tumor suppression in preclinical models using nanots against tumor-generated soluble immune inhibitors. We've demonstrated ultra-rapid prototyping. We've shown that the shielding works perfectly, and it has an excellent safety profile. We haven't seen any toxicity at 100 times the planned human dosing. In terms of applications, we're focusing on a broad range of inflammatory diseases and cancer, targeting disease-specific soluble factors in blood. And this grid is a subset of a much larger grid that helps us plan and prioritize our targets and diseases. On the left is inflammatory diseases and targets. The x-axis is the diseases. The y-axis is the targets that are relevant. On the right are suppressive diseases. Cancers are all suppressive. They can't survive without immune inhibitors, which are on the y-axis there. And our premise, which we think is fact, is that a very small number of soluble signals drive or enable a large number of diseases. And the nanot chemistry is modular, so changing targets and diseases simply requires swapping out one capture agent for another. For instance, to target soluble TNF, which is implicated in a very broad range of inflammatory diseases, you just put in a capture agent against that. It will rapidly diffuse soluble TNF from circulation and interrupt the diseases that depend on soluble TNF. Likewise, if you want to take out an inhibitory target, you just swap out the capture agent, for instance, for soluble TNFR1, and it will rapidly deplete that from circulation, creating a diffusion sink, which induces migration out of the tumor microenvironment. We also have combination treatments. Some diseases really require taking out more than one target. For instance, multiple sclerosis, and here's the first QR code if you'd like to download our white paper on that. We also have a program on sepsis. No one has ever cracked sepsis, kills more people than all forms of cancer combined. We know the targets, everybody knows the targets, there's just no way to extinguish them rapidly. The nanot platform is perfect for that. And here's the QR code for our white paper on sepsis. This will be the most valuable drug ever created if we succeed, just because of the sheer number of cases. Okay, so let's focus on soluble TNF receptors as a core mechanism of tumor immune evasion. So we know that soluble TNF depletion is powerful because there's dramatic clinical human data on the treatment of late-stage metastatic cancer via depletion of STNFRs by pheresis. Now, NaNots are a better method than pheresis in every respect, but it's still great to have human data already. This is a clinic in Germany that operated for over a decade, and they treated cancer simply by depletion of STNFRs as a monotherapy. And they documented an overall response rate in a patient population that already had failed standard of care, where no improvement would be expected. They showed a 60% overall response rate and a 23% complete response, remission. And if you look at Keytruda in phase 1, we have that data. It documented just 16% ORR and a 6% CR, and despite that, it's the best-selling drug of all time. So a big question is, how could STNFR depletion outperform the leading checkpoint inhibitor? And the best way to understand this is to refer to the cancer immunity cycle by Melman and Chen of Genentech. So this is the most widely used model of immune response to cancer, which presents points of potential intervention for immuno-oncology drugs. And what's already known is that 6 of 7 steps in the cancer immunity cycle are potentiated by TNF. They won't happen without TNF. And that's why it's so fundamental that cancers all secrete soluble TNFs. They just cleave off their soluble TNF, they cleave off their membrane TNF receptors into a soluble form. And that drives down TNF and interrupts the cancer immunity cycle. All right, so we use anti-STNFR NaNots to increase available soluble TNF. We tested this in a mouse model of colon cancer, CT26, at Crown Bio, and we engaged their RNA-seq team as well. And what we found is that NaNots against soluble TNF delivered a transcriptomic trace that confirmed that every part of the cancer immunity cycle had been activated. So anti-STNFR NaNots drive the cancer immunity cycle at almost every step, 6 of 7, whereas checkpoint inhibitors like Keytruda only drive it at one step in the cycle. And there's no other drug that can do that. Okay, so we also had to do an efficacy study. So we used a mouse model of triple-negative breast cancer, which is a metastatic model. This is 4T1. And NaNots had 5 times the number of metastasis-free survivors compared with control and also the mouse equivalent of Keytruda. And we're moving this forward in collaboration with Mass General under Keith Flaherty, who's a legendary developer of cancer immunotherapies. Okay, so here's a white paper on STNFRs for those of you who are interested. It's very detailed, and it goes into both the history of STNFRs as well as our treatment. All right. You might be asking, if STNFRs are such a great target, why haven't we drugged it? And the answer is, it's undruggable. A drug against soluble TNF receptors would also bind and block membrane TNF receptors, and that's essential for immunity. But NaNots have the unique capability to deplete soluble TNF receptors without blocking membrane TNF receptors. And that actually is a great introduction to the advantages of NaNots over antibody drugs. The first is what I just mentioned, soluble target specificity. So many targets have both an essential membrane form, doing something important, and they have a soluble target, which is pathogenic. These 2 targets are biochemically identical. Antibody drugs use chemistry to target, so they can't distinguish between these. So what happens, you put the antibody drug in, it binds both the membrane form and the soluble form, and it abrogates the benefits of membrane signaling, which is detrimental. Now, if you put a NaNot in, what happens is it will adsorb the soluble target, but the NaNot shielding prevents any engagement with the membrane form. That gap you see is a literal gap. It creates space against the membrane target, and the membrane signal gets through. So the second big advantage of NaNots over antibody drugs is that there's no target accumulation. And people don't necessarily understand that antibody drugs don't make targets go away. They actually stabilize them and amplify them over time. Because antibody drugs generally have a long half-life, and they accumulate the target. But antibody binding to a target is reversible. the target is constantly bouncing on and off the antibody. And over time, you end up with more and more conjugate of antibody and target, and that means you end up with more and more of a reservoir of bioactive target that is off the antibody at any moment. Now contrast that with how nanots work, which is they capture their target, they're immediately cleared by macrophage phagocytosis. It's rapid, irreversible target depletion, typically 95% target depletion at the 5-minute time point post-injection. Contrast that with pheresis, which takes 3 to 4 hours to deplete the same targets and is hard-pressed to go beyond 70%. And then nanots and their targets are cleared by macrophage phagocytosis. And number 3, in terms of advantages, is that there won't be any anti-drug antibodies or loss of response. And that's because of the nanot shielding. So typically, what happens with a drug that you take on a chronic basis is that B cells encounter the drug and treat it like an antigen and generate anti-drug antibodies against it. That won't happen with nanots because of the shielding. Nanots, the B cell has no way to build intelligence about the capture agent because it can't reach into the nanot to touch the capture agent. Okay, so let's talk about another oncology target, which is soluble PD-L1, and this is one that we're exploring with Mayo Clinic. So soluble PD-L1 is simply the soluble form of membrane PD-L1, which is a very well-characterized inhibitory ligand that multiple cancer cells project, as do multiple normal cell types. So we're working with Mayo Clinic, and their team includes the co-discoverer of PD-L1. We made nanots against human soluble PD-L1. They tested that in a humanized mouse with a triple-negative breast cancer tumor, and they demonstrated profound tumor suppression. And this is a model that doesn't generally respond to checkpoint inhibitors. And they presented a poster recently at SITC, and there were some really interesting implications that came through in their research. One being that nanots induced a remodeling of the tumor microenvironment. What you want your immunotherapy to do is reduce the population of Treg cells and increase the population of T effector cells. Treg cells are suppressive, they're pro-tumor. And we saw a very positive ratio of those cell types in the nanot cohort. When you dig further into the T effector cell cohort with immunophenotyping, you find that the effector cell cohort had reduced population of exhausted CD8 T cells, which aren't going to do you any good going forward, and an increased population of stem cell-like CD8 T cells, which are your next generation of cytotoxic T effector cells. And this remodeling was achieved solely by depletion of soluble factors. No drugs, no other modality. All right, I want to talk about my favorite target of all, which is soluble IL-6R. I think it's the coolest. Okay, so we're developing nanots against soluble IL-6 receptor for rheumatoid arthritis and other inflammatory diseases. So we know that IL-6 is centrally involved in a broad range of pathogenic conditions. And generally these get grouped, including aging, get grouped under trans signaling, which is the pro-inflammatory type of IL-6 signaling. There's another type of IL-6 signaling called classic signaling, which is almost always positive. It's reparative and restorative, and it's involved in a variety of homeostatic processes. Well, how do we understand this, that one molecule could drive two different types of signaling that are really oppositional? And the answer is that two different cell types mediate these two different signals. Hepatocytes and immune cells mediate classic signaling. All other cell types are capable of trans signaling. On the classic signal side, you have an actual transmembrane receptor, even though it's non-signaling. So the IL-6 cytokine binds to the IL-6 receptor, and those are non-signaling receptors, by the way. They don't have an intracellular domain. And they draw in GP130, which is a glycoprotein. That forms a heterohexamer, which signals strongly this positive anti-inflammatory protective signal. Well, how does trans signaling happen on cells that have no IL-6 receptor? And the answer is they form a receptor on the fly, because we all have high levels of soluble IL-6 receptor in our blood. So the cytokine binds to those soluble receptors, which in turn draw in the GP130 and transduce this negative signal into cells, even cells with no IL-6 receptor. Now, there are drugs against IL-6 and IL-6 receptor, tocilizumab against the receptor, but they can't distinguish classic signaling from trans signaling. So, for instance, tocilizumab will bind and block the trans signal by blocking the soluble IL-6 receptor, but it'll also bind and block the membrane receptor. So your trans signaling gets interrupted, but your classic signaling gets interrupted too. So that's bad. And I won't go through it, but drugs like siltuximab that target the cytokine rather than the receptor, of course, they have the same problem. So what's our strategy? Well, we're gonna use nanots against the soluble form of the receptor. We'll take that out, but the nanot shielding will prevent any engagement at all with the membrane receptor, which is essential for classic signaling. So we abrogate trans signaling, and we allow classic signaling to go through. Now, I know we're all excited about IL-11, given that it was published in Nature just last month. So let's talk about this. Treatment with anti-IL from 75 weeks of age until death extends the median lifespan of male mice by 22.5% and of female mice by 25%. And I believe that Anissa Wijaja, one of the co-authors of this study, is here and presenting this afternoon, so that should be really interesting. And there's a QR code for her paper just to save you the trouble of downloading it. Okay. All right, so let's look at IL-6 and try to deconvolute the signal. So IL-11 is in the IL-6 family. They're very closely related, and you have the same type of heterohexameric signaling complex, just like IL-6. And the elements for IL-11 trans signaling exist, but there's no evidence yet that trans signaling ever happens on the IL-11 pathway. And there's a bunch of evidence that I don't have time to go into that suggests it probably doesn't happen. So let's reframe this. Rather than discussing IL-11 in the context of classic signaling, let's call that instead positive signaling. And instead of trans signaling, let's call that negative signaling. Now, studies from 1995 to 2015 showed that IL-11 is anti-fibrotic, anti-inflammatory, and pro-regenerative. So not surprisingly, there was an effort to turn it into a drug, and in fact, one was developed using recombinant human IL-11, which protected mice against a variety of diseases. But newer studies show the opposite, that IL-11 is actually pro-fibrotic, pro-inflammatory, and anti-regenerative. And further studies showed it's upregulated with age and induces senescence in human cells. Well, of course, the questions come flowing in, like how can we explain that? And what's really cool about the work that Wijaja and Cook did is that they showed that human IL-11 is non-signaling in mice and blocks murine IL-11. So the reported benefits of those early studies actually stem from blocking IL-11, not the administration of IL-11. In other words, the assumed gain of function was actually loss of function. And Wijaja and Cook argue that IL-11 has no essential function, and neutralization systemically is therefore safe. I would ask, are we sure about this? Because there's a really fine paper by Dong et al. In 2023 that states IL-11 deficiency leads to reduced bone mass and formation, as well as adiposity, glucose intolerance, and insulin resistance. And Cook is aware of this. In 2023, he wrote, the situation regarding IL-11 signaling and osteoblast, osteocyte, osteoclast activity, and bone homeostasis is complex and difficult to resolve, which sounds like a punt to me. So the big question is, how serious will these issues be in humans taking anti-IL-11 antibodies long term? So we're going to make a nanot against IL-11. Why not? We can target either the cytokine or we can target the soluble receptor or both. We know it'll deplete IL-11 from circulation deeply and rapidly. It will not extravasate into bone, which may potentially avoid bone issues. It will not lead to target accumulation like an antibody, and it will not induce anti-drug antibodies and loss of response, which is critical for any drug you're taking for the rest of your life. It's a promising target. Nanots may be the best way to clear it. We'll find out. Thank you very much.
Thank you so much, Lou. We have time for maybe 1, 2 questions.
That's really interesting. So I was wondering, can you do quality control at scale that it's only binding soluble?
What do you mean by quality control?
So if you bring this to the clinic, you need to be sure that your shield is intact. So can you do this at scale?
Yeah, we've tested the shield. Well, we haven't made them at scale, but there's nothing about how we make them that means the shield's going to work less well at scale. The shield is sort of the easy part. It works really, really well. QC. All I can say is that the process we're using, even though no one has made a nanot before, people have made nanoparticles for drug delivery, and every part of the method we're using has been used before and QC'd before as well.
Thank you. Just understanding the liver accumulation or the toxicity of the certain nanots going to be specifically in the TME, the tumor microenvironment, or you also target, because they're going to be accumulating in the liver, what's going to be the toxicity of this in terms of safety? I might have missed it. You might have already shown the safety.
Right. So we've tested nanots at 100 times the planned dose, clinical dose. We haven't seen any morbidity or mortality in rodents, and we haven't even seen any perturbation of their cytokine networks. The materials are safe, also very, very low dose. So in other words, 95%, we dose nanots at 1 to 2 mg per kg, which is very low for a drug, and 95% of that is inert. It's inert silica. So a tiny, minute amount of that is capture agent, and it's never presented to a cell other than when it gets phagocytosed. It's only it's only capturing soluble targets. Okay.
All right. Thank you so much, Lou.
Thank you, everybody.
Give him a warm round of applause.